You treated it. You followed every instruction. You took the medication, used the cream, cut the nail down as far as it would go. And for a few weeks, maybe even a few months, it looked like it was finally gone. And then it came back. Same nail, same color, same creeping thickness along the edge, like the whole thing never happened. If that sounds familiar, I want you to stay with me for the next few minutes. Because the reason nail fungus keeps coming back has almost nothing to do with your nail, and nobody is telling you what it actually is. The clinical study of nail disorders and fungal disease. I've been practicing for 19 years, and for the last 12 of them, recurrent onychomycosis, that's the medical term for nail fungal infection, has been one of the most common things I see walk through my door.
I started making these videos because of a patient named Gerald. He was 63, a retired electrician, very practical man. He had been treating the same toenail for 4 years. 4 years. He'd done 2 full rounds of oral antifungal medication, the kind that requires liver monitoring. He'd used prescription lacquers. He'd tried every over-the-counter product on the shelf. And every single time the nail started to look better, the fungus returned within 6 months. When he sat down in my office, he wasn't angry. He was just tired. He said to me, "Doctor, am I doing something wrong? Because I feel like I'm fighting something I can't see." He wasn't wrong. He was fighting something he couldn't see. And that's exactly the problem. Here's what most people believe. If you treat the nail long enough, the fungus dies and it's over. That feels logical. That's what the packaging implies. That's what a lot of physicians, unfortunately, don't correct. But here's what's actually happening. The nail itself is not where the fungus lives. Not permanently. The nail is a structure, a hard, dense plate of keratin. What the fungus is doing underneath that plate, in the nail bed, in the lateral nail folds, and in the skin of the surrounding toe, is building a reservoir, a biological hiding place. And when the medication pressure lifts, even slightly, it repopulates from there. I always explain it to patients this way. Imagine you have a leak in your ceiling. You can patch the ceiling 100 times. But if the pipe behind the wall is still broken, the water is going to find its way back. The nail is your ceiling. The pipe is everything the nail sits on top of. Research published in the Journal of the American Academy of Dermatology found that even after clinically successful treatment, meaning the nail looked clear, fungal DNA was still detectable in the nail bed tissue in over 40% of cases. 40%. Those patients weren't cured. They were temporarily suppressed. So the practical question becomes, how do you address the reservoir, not just the nail? We'll get to exactly that. But first, there are a few things that make this reservoir dramatically harder to eliminate. And one of them is something you're almost certainly doing every single day. When someone comes back to my office with a recurrence, the first thing I ask them, before I look at the nail, is, "Where do you keep your shoes?" They usually look at me like I've asked a strange question, but it's not strange at all. Dermatophytes, the family of fungi responsible for most nail infections, can survive inside footwear for months, not days. Months. The warm, dark, slightly humid interior of a shoe is essentially a perfect incubation environment, and every single time you slide your foot back into that shoe, you are reintroducing the organism to skin that may have just finished a treatment cycle. Think of it like this. You wash your hands after touching something contaminated, but then you put on contaminated gloves. The washing accomplished nothing. The CDC has documented that dermatophyte spores can remain viable on surfaces including textile fibers for up to 12 months. Your running shoes, your work boots, the insoles, all of it. The simple, immediate action here is antifungal spray or powder applied to the inside of shoes, especially shoes worn without socks or shoes worn during high sweat activities. Rotating footwear so no single pair is worn multiple days in a row also dramatically reduces fungal load. But the footwear issue, as significant as it is only half of the external reinfection story. The other half lives somewhere far more personal. This next point is the one I wish more people asked me about. It almost never appears in patient materials. And when I explain it, I watch people's expressions shift because it suddenly makes sense of a pattern they could never explain. Nail fungus and athlete's foot are caused by the same organisms. Trichophyton rubrum accounts for roughly 70 to 80% of both conditions, according to data from the National Institute of Allergy and Infectious Diseases. They are the same infection in two different locations. What that means in practice is this: if you successfully treat the nail but you have any residual fungal presence on the skin of the foot, the sole, the heel, the web spaces between the toes, that skin becomes a direct pipeline for reinfection. The fungus migrates. It travels along the nail fold, finds the hyponychium, that small gap where the nail detaches from the bed at the free edge, and it re-enters. I always describe it as a bridge. You treat one side of the bridge but not the other, and the traffic, the fungal organisms, just keeps crossing. Many patients I've seen treated their nail infection for months while completely ignoring mild, barely visible athlete's foot symptoms on the same foot. Symptoms that felt like dry skin, slight flaking between the toes, a little extra roughness on the heel. Nothing dramatic. At night, when you're still, when the foot is warm under the covers and there's nothing pulling your attention away, that's often when you'll notice a faint itch between the toes. A slight burning under the ball of the foot. Pay attention to that. It matters more than it seems. The practical action. Any treatment protocol for nail fungus should include simultaneous treatment of the surrounding skin. An antifungal cream applied to the entire foot, not just the nail, for the full duration of nail treatment. Not as an afterthought. As a requirement. Mid-script engagement moment. Before we go further, I want to ask you something directly. Have you ever treated a nail infection more than once? Type yes in the comments if this has happened to you more than twice. I read these, and I want to understand how widespread this actually is, because I think the number is higher than most people realize. Here's where it gets serious. A 2021 meta-analysis in the British Journal of Dermatology found that patient non-adherence to full treatment duration was the single most predictive factor in nail fungal recurrence. More predictive than which medication was used. More predictive than the severity of the initial infection. And the reason most patients stop treatment early is completely understandable. The nail looks better. The yellow is gone. The thickness is reduced. It feels like victory. So they stop. But here's the biology of what's happening. The nail you're looking at right now is not the nail that was infected. Toenails grow approximately 1 to 2 millimeters per month. A complete nail replacement takes 9 to 12 months. What you are seeing when the nail looks clear is new nail growth pushing the infected material toward the free edge. The nail bed beneath, where the active fungal reservoir lives, may still be colonized. I explain it to patients like this. Imagine you're watching a glacier calve. You see a massive piece of ice break off and drift away. But the glacier itself, the source, hasn't moved. The infected portion of the nail is calving away. The source is still there until the full growth cycle is complete. Topical antifungals require a minimum of 48 weeks of consistent daily application for toenails. Most people stop at 16. That's the gap. That's where the recurrence lives. Let that sit for a moment. 48 weeks. Most people stop at 16. Not because they're careless, because no one told them why the full duration isn't optional, and it connects directly to what I want to show you next. Because everything I've described so far, the reservoir, the skin bridge, the treatment duration, all of it becomes exponentially harder to overcome when the immune system isn't working at full capacity. Dermatophytes are not aggressive pathogens in immunocompetent individuals. Healthy immune function is normally sufficient to keep fungal colonization from becoming a deep, persistent infection. But when immune function is reduced, and there are several very common reasons it might be, the organism gains a foothold that medication alone cannot always overcome. Poorly controlled type 2 diabetes is the most significant systemic risk factor for recurrent and treatment-resistant onychomycosis. The American Diabetes Association reports that roughly 1/3 of diabetic patients will develop nail fungal infection during their lifetime, a rate 3 to 4 times higher than the general population. The combination of reduced peripheral circulation, impaired neutrophil function, and elevated glucose in tissue creates an environment where fungal organisms thrive and antifungal medications struggle to reach therapeutic concentration. But you don't have to have diabetes for this to apply to you. Chronic stress, long-term steroid use, autoimmune conditions, even severe sleep deprivation, which measurably suppresses T-cell response, can tip the balance. The fungus isn't getting stronger. The environment it's growing in is becoming more hospitable. I think of it like a garden. You can pull weeds every day. But if the soil conditions are perfect for weeds, the moisture, the nutrients, the sunlight, they will always return faster than you can pull them. Changing the soil changes everything. If your nail fungal infections keep returning, despite doing everything right externally, this is the conversation to have with your primary physician. A fasting glucose, a hemoglobin A1C, an immune function panel, not because something is definitely wrong, but because the body's internal environment is part of the treatment equation, and it's the part that gets left off the prescription pad. And this brings me to something almost nobody talks about, not in the exam room, and certainly not in the instructions on the antifungal packaging. You can do everything right and still be reinfected by your own household. Fungal spores shed from infected nails and skin contaminate shower floors, bath mats, and shared flooring. A 2019 study in mycoses found dermatophyte contamination in the bathroom environments of 67% of households where at least one member had an active nail fungal infection. 67%. The bathroom floor that the rest of the family walks on barefoot. The bath mat everyone steps onto after showering. The communal area of the house. And this creates a cycle that can last years without anyone understanding why. One member of the household treats their infection. They're reinfected from the shared bathroom environment, or they unknowingly transmit it to a partner who has a mild or subclinical case who then becomes a reservoir for future reinfection of the original patient. Gerald, the patient I mentioned at the very beginning of this video, this was his answer. When we finally did a full environmental assessment, his partner had a mild asymptomatic case that had gone undetected. 4 years of treatment. The source of reinfection had been in his own home the entire time. He didn't say much when I told him. He just sat quietly for a moment. And I understood that it was quiet. It wasn't frustrating. It was the specific exhaustion of finally understanding something you'd been fighting blind. The practical steps here: antifungal sprays applied to shower floors and bath mats weekly during any active treatment period. Personal shower footwear that is not shared. And if someone else in your home has or has had nail fungus, that conversation needs to happen, not as an accusation, but as a clinical reality. Closing. Emotional through-line resolution. I want to come back to something for a moment. If you've been treating this for years, if you've done everything you were told and watched it return anyway, I want you to hear this clearly. You didn't fail the treatment. The treatment was incomplete. Not because of anything you did wrong, but because the information that would have made it complete was never given to you. The nail is the last place to show the infection and the last place to show the cure. Everything that matters is underneath it, around it, and in the environment it lives in. Treat all of those: the reservoir, the skin, the footwear, the bathroom, the systemic baseline, and you change the outcome entirely. Tonight, one thing. Look at your shoes. The ones you wear most often. Spray the inside with an antifungal. It takes 20 seconds, and it closes one of the most common re-entry points that nobody mentioned to you. If this video gave you something your doctor's visit didn't, share it with someone who's been dealing with this silently. They may not even know they're frustrated yet. They may just think it's the way things are. It doesn't have to be.